Good evening, everybody, and thank you for joining us this evening for our webinar on aortic stenosis. How urgent is aortic stenosis with Dr. Shailesh Khatri? So just before we get started with the presentation, a few housekeeping points that we would like to run through. First of all, if you do have any issues with the platform that we're using, please feel free to use the chat function just to let us know, and we'll be able to help you through and hopefully get all of that solved for you. Also, if you do have any issues with seeing or hearing anything, or if you do need to leave early, there will be a recording provided of tonight's webinar, and we'll be emailing that out to everyone who attended after we finish, probably tomorrow. And for tonight's presentation, we do ask that everybody remain muted through the presentation, and you are certainly invited to send through any questions that you might have throughout the presentation as we go through. That's fine. And we just ask that you could either use the chat function to the presenters, not the whole group, or the Q&A function, and we'll be able to address the questions as they come through, and Dr. Khatri will be invited to speak to those at the end of the presentation. So without further ado, it is my absolute privilege and honour to introduce our presenter for this evening, Dr. Shailesh Khatri, an interventional cardiologist from the Cardiac Centre. Dr. Khatri, thank you very much, and we look forward to what you have to present this evening.
Thank you, Jason. My name is Shailesh Khatri. I'm an interventional cardiologist here at John Flynn Hospital in Gold Coast, and thank you for giving me this opportunity to talk about aortic stenosis. So today we'll talk about pathophysiology, etiology, prevalence, symptoms and prognosis for severe aortic stenosis, and we'll also talk about some cases that I have been involved with. Aortic stenosis is a very common condition that we see, and in terms of management, we're looking at newer options, specifically in terms of patients who cannot tolerate a surgical aortic valve replacement. So aortic stenosis is in a lot of ways similar to atherosclerosis. It is solid calcium deposits within the valve cusp, and the risk factors is very similar to coronary artery disease as well. We tend to see a lot in the 6th, 7th and 8th decades of life, and quite often patients with aortic stenosis will also have coronary artery disease. Now, why is it important? It is important because when patients develop severe aortic stenosis, their prognosis is quite heavily impacted upon when it is picked up and when something is done about it. So if you look at this slide here, patients may not have much symptoms, and then when they become symptomatic, the survival drops off very quickly. So if you look at patients who have onset of symptoms, and if nothing is done, then they may not live half of them may not live beyond 2 years. So that's pretty important. So shortness of breath, angina and syncope are the usual symptoms that one would see with severe or critical aortic stenosis. Now, if you look at the prevalence of aortic stenosis, and if you look at different age groups, over 65, we're looking at 2% of the population. It goes to 3% over 75, and over 4% in the over 85 age group. And obviously, as the age increases, the comorbidities also increase, especially in terms of risk of a surgical aortic valve replacement. And that is the reason why we're talking about TAVI today, because patients are living longer, and these patients would otherwise not benefit from a valve surgery because they're just too old or have too many comorbidities. So how do you diagnose aortic stenosis? Well, we've all learned in our medical schools that we have to actually take a history, and so we just talked about history, that in shortness of breath, chest pain, pre-syncope, syncope, and then it comes down to physical examination. So peripheral signs you would be looking for is a slow rising, slow volume carotid pulse, a narrow pulse pressure, and a sustained heavy apex beat that is not displaced, unless it's obviously heart failure. In terms of auscultation, it's the second sound is of lower intensity, and you tend to hear a mid to late peaking systolic murmur, heard best at the base. The murmur may radiate to the carotids as well. So that's the clinical signs. I mean, sometimes if they've got associated heart failure, you may also get obviously some basal crackles in the lungs as well. Once you've done the physical examination, the other things that would be included would be an ECG. ECG may be a sinus rhythm. It may show signs of left ventricular hypertrophy, or even some ischemic changes as well. Echocardiogram would be considered the cornerstone of diagnosis for severe aortic stenosis, and echocardiogram gives us a lot more information about the aortic stenosis as well as their heart function. So we can look at the valve, we can look at the different chambers, and we can see if there's anything else going on as well. So once we've decided that the patient has severe aortic stenosis based on the history, physical examination, echocardiogram, then the next step is usually cardiac catheterization. Why would we do a cardiac cath? Well, we want to know a bit more. Quite often we look at the hemodynamics across the and check that the gradient across the aortic valve is correlating well with what the echocardiogram showed, and then obviously we're trying to exclude coronary artery disease, which the patient may or may not have. So if the patient does have coronary artery disease, then we can decide how we're going to manage this. If the patient, for example, is for TAVI, then we will fix up the coronary disease with stenting. Or if the patient is not for TAVI and we've already decided needs a surgical valve, then the surgeon needs to know what sort of coronary disease the patient has, so that whilst he or she is fixing up the valve, coronary artery bypass graft surgery is performed in the same sitting. So if you look at this slide, I mean, it's a pretty busy slide to see how best to assess the severity of aortic stenosis and how you would manage them. And the easy one is the high grade aortic stenosis with a a mean gradient of 40 millimeters mercury and a valve area of less than 1 centimeter squared. It's easy. Patients have got severe aortic stenosis, and something needs to be done about it. Then you have the low flow, low gradient aortic stenosis with reduced ejection fraction, or the same low flow, low gradient aortic stenosis with preserved ejection fraction. So this may or may not be severe aortic stenosis. We need to look further into it, and if we do decide that it is severe, then obviously the valve needs to be treated. Or if we decide that it is normal flow, low gradient aortic stenosis with preserved ejection fraction, and come to the conclusion that it's moderate aortic stenosis, then obviously we would not be treating this valve, at least not for the moment, until the valve becomes progressively more stenosed. So there's a process of determining how severe the aortic stenosis is, and then proceeding accordingly. So there are guidelines as to which ones need to be treated. So high gradient aortic stenosis, as I just mentioned, with a mean gradient more than 40 millimeters mercury and a peak velocity of greater than 4 meters per second, intervention is recommended, and the indication is a class 1B indication. Then you got the low flow, low gradient with the reduced ejection fraction. Once again, intervention is recommended. It's a class 1C indication. And then you got the low flow, low gradient with preserved ejection fraction. It may or may not need to be considered. So we make these decisions based on what the patient characteristics are. Or I also look at other things apart from what I've just discussed. So when we're deciding a TAVI versus a surgical aortic valve replacement, we look at the risk factors, and the common ones that we use is the STS or the Euroscore, and look at other comorbidities. So if they comorbidities are more, or if they have a high Euro score, then it favors TAVI compared to as the surgical aortic valve replacement. So, and if their score is low, then a surgical valve replacement is favored because the complication rate for this population is very low. The other things we look at is the age. Once again, that is all changing. So age less than 75 at the moment is surgical, age more than 75 is TAVI. If they've had previous cardiac surgery, you tend to favor TAVI. If they're frail patients, once again, TAVI. And then if you look at on the right side, what other things? We look at technical aspects. So if they have got good favorable access from a femoral side, then TAVI would be favored. But if it's unfavorable access, could be femoral, could be subclavian, then, and if it's not favorable for various reasons, then surgical option would be the favored option in that case. The other things we look at is previous chest radiation from radiotherapy, a porcelain aorta, presence of absence of bypass grafts at risk of stenotomy, then in that case TAVI is the favored option. So all these things we look at when we're making a decision. What about other characteristics that would favor the surgical approach? That would be severe coronary artery disease, which would not be amenable to stenting. So in that case, we would be going for the surgical approach. Or if they've got other valvular heart disease, which we will not be able to fix at the time of the TAVI, or even at a later date, even a staged procedure, then we would favor surgical valve replacement. So there are many different things that we look at when we're making a decision as to whether the patient has TAVI or goes down the surgical pathway. So we do classify them as low risk, intermediate risk, high, and extreme. So at this point in time, anybody looking at intermediate, high, and extreme risk, they go for TAVI. Low risk at this point in time, they still have surgical aortic valve replacement. This is what it is today, but in time to come, in the next year or two, even the low risk patients will be most likely going for the TAVI procedure. So watch this space. So patient selection, we look at whether it's predominantly aortic stenosis. If it's predominantly aortic regurgitation, they're not very suitable for the TAVI procedure. So we need to determine what is the main reason that we are suggesting one procedure over the other. If you look at the contraindications, there are quite a few. So bicuspid valve, for example, if the annulus is very big or very small, if they've got asymmetric heavy valvular calcification with the risk of compressing coronary arteries or occlusion of coronary arteries during the procedure, then we may tend to favor the surgical approach. Or if they've got LV thrombus or the aortic root is very big. So once again, there are many things we look at when we're deciding whether the patient has TAVI or not. So if you look at this slide, there are many different approaches that we use in delivering the TAVI valve. Transfemoral is the most common approach. If it is not suitable, then we look at subclavian axillary approach. Then there is the option of direct aortic approach or the transapical. Most of the ones that we have done, it has been transfemoral. We've done a small number of subclavian. They have been successful as well, and we haven't had the need to use the direct aortic approach or the transapical. So people are tending to move away from those anyway. So in terms of the procedure, when we first started this here, we were doing them under general anesthetic, but we've moved away now to sedation, and the procedure can be done just like doing an angiogram and angioplasty. Obviously, this procedure does not require any heart-lung bypass machine, and the catheter is placed transarterially, and the procedure can take anywhere from 1 to 3 hours typically, but we've been doing them, some of them within 40 minutes from skin to skin, so it can be done very quickly. In terms of how long the patients stay in hospital after the procedure, well, once again, it depends on how good they are before they came in. If they're very frail, they may stay a little longer. If they've had some complications, obviously they're going to stay a bit longer. But on average, 3 days. So most often when we do the procedures here, I do them on a Monday, Wednesday, they're gone home. So usually only 2 days, really. In terms of total recovery, 1 week, but as I said earlier, it depends on their pre-morbid conditions as well. If you compare that with surgical patients, they tend to spend at least about a week in hospital from the day of surgery, and it takes good 6 to 8 weeks to recover completely. So there's a big difference in terms of recovery. If you're looking at this slide here, there's lots that goes on in terms of how the patient is picked up first as needing to have the TAVI procedure, what investigations they have, what visits they have, how long they spend in hospital, and what sort of follow-up they have. These are all the steps, or most of the steps, each and every patient goes through. I won't go through them because it's a very busy slide, and I don't think we need to be worrying too much about that at this point in time. So in terms of the TAVI valve, we've been using the Medtronic valve, and we first started off with the core valve and then moved on to the valvular system. So it's a nitinol mesh, as you can see there. It comes in various sizes and different delivery systems as well. So that's what the valve looks like when it's in the jar, and when we're implanting them, we have to put them through this loading system. It's compressed, and then it's delivered to the patient. This is what we call a self-expanding valve. It confirms and seals the annulus. And the good thing about this valve, although the original core valve wasn't, that it is recapturable. So when we're not happy with the position of the valve before we've released it completely, we have the opportunity to recapture the valve, place it in the appropriate position, and then once we're happy, then we release the valve. It's a supraannular design. It's a porcine pericardial valve. It takes a lot of work to sew the porcine material onto this frame, and yeah, it's quite a complex procedure. In terms of the characteristics of the valve, as I said, it's thin for low profile delivery. It has got good strength, and once the valve is deployed, it does maximize flow and optimizes coaptation. It works quite well once it's released. So this is the delivery system. This is what it looks like when we putting this catheter or mounting the valve onto this catheter and then delivering it to the patient. So if you look at this valve, how we actually deliver the valve, we've crossed the aortic valve. We've got this wire in the left ventricle, and the wire is obviously coming out to the femoral artery. We thread the catheter up, get across the aortic valve, and once we are happy with the position, then we start opening it. So the next slide, the second slide, which says annular contact, we've just made contact, and the valve is about a third open, and then once we open to the next position where it says the functioning valve, meaning that the valve has not been released, but the valve is actually functional, and we can see that on the hemodynamics. And once we're happy that we have delivered in the right position, then we release the valve completely, and that's what you see on the far right. This is what it looks like once it's deployed. It opens up like a circle, but it all depends on the calcification and the anatomy of the patient, whether it will look circular, it may look a bit ovoid as well. This is what it looks like from the top once it's deployed. That's on the right side. It's fully open, and you hope that you have not compromised the coronary arteries. So some clinical data. I'm just going to go very quickly through this because I don't think I need to bore you with all the data. Suffice to say that Medtronic has done a lot of studies, and these are just a small list of many studies that they have done. A lot of them have had a good number of patients enrolled in each and every of this study and have had good follow-up. If you look at mortality and stroke, these are from the early trials. Yes, there is people do die and some people do have stroke, but as we have evolved over time in terms of our experience and the nature of the valve, the mortality and stroke rates have gone down. This is the SIR-TAVI trial data. You can see comparing the surgical valve, that's the SAVA, versus TAVA, which is the TAVI. They are very similar in terms of mortality, stroke rates, but if you come down in terms of patients having major bleeds, or patients requiring blood transfusion or kidney damage, well, some of them, depending on which arm they were enrolled in, you'll see that in the surgical group, they needed more transfusion and they had more kidney damage compared to the TAVI group. This is from the early studies, so the pacemaker rate was quite high, 25% versus 6%, and I'll show you some information later that the pacemaker rates have dropped over time. So here's this next slide. We're looking at the early studies, 21% there, 19%, but now we're looking at 11 to 16%. So the pacemaker rates have definitely reduced over time. If you look at how the patients do after the valve has been implanted, so whether it's a surgical valve or the TAVI, if you look at 30 days and looking at the 6-minute walk test, obviously the TAVI patients are doing a lot better and the surgical patients not, mainly because they're still recovering. It's not the valve, but they're still recovering from their surgery. But if you look at 12 months, both are doing not bad, but the TAVI patients are definitely doing better. So in terms of summary, that Evolute R valve works well, and there's a good safety data now following up to 2 years or more. If you look at the Evolute R real world studies, there's lots of them as well. Once again, there's a long list here. I won't bore you with that, but basically in the real world setting, which often looks at patients who might have been otherwise excluded from randomized studies, the patients have done well. They have low mortality, low stroke, and tend to have a mild aortic regurgitation and no problems with any coronary obstruction or annular rupture. And that's from this Ford study data. And the Evolute Pro basically is very similar to the Evolute R, except what it has, it's got this pericardial wrap, which what it does, it helps to reduce the aortic regurgitation that we were seeing in some of the patients with the first and second generation stents. Once again, good clinical data from the Evolute Pro valves as well. So I think I've given you enough background information. I want to now focus on some of the case studies. These are my personal patients that I have treated, and I thought I'd show you two patients that really show very well how this new procedure is effective in treating them. So this was a young patient actually that I saw recently. She was a 58-year-old female, no cardiac history whatsoever, and then came to see me with 3-week history of shortness of breath on exertion and a nocturnal cough and nothing else. So she came for an echo and to be followed up by a consultation with me. It was on a Friday afternoon. My tech came running to me after doing this echo, said this patient is very unwell. So what did we find? Well, this was a 58-year-old female who was really struggling. She had severe LV dysfunction, ejection fraction of 15%. She had critical aortic stenosis. Even with that poor LV function, she was generating a mean gradient of 53 millimeters mercury, and her valve area was very small, 0.5 centimeters squared. in association with those valvular problems and the severe LV dysfunction. She had moderate to severe mitral regurgitation. She had moderate tricuspid regurgitation and a small pericardial effusion. It was late on a Friday, as I said. I had to admit her to hospital and start medical therapy and figure out how I was going to manage her moving forward. Anyway, I'll just show you some echo here and see what it looked like. So if you look at it, it's a very calcified valve. The left ventricle is not pumping very well, and I'll move on to the next slide. So here another view of the same. You can see that the left ventricle is hardly contracting. So she's got severe LV dysfunction. On this slide you can't really appreciate how narrow the aortic valve is, but you can see it's very calcified. So I'll show you more pictures of the same. So this is now we've got the Doppler there, and you'll see that she's got moderate to severe mitral regurgitation. That's the jet going down from the mitral valve. And if you look at the aortic valve, there's also moderate aortic regurgitation there as well. So she was in a lot of trouble, this lady. So basically, she got admitted for optimization of a heart failure. Then we decided that she should have a bi-V ICD to help improve her heart function and protect her from any malignant arrhythmia. With that kind of valvular heart disease and the severe LV dysfunction, she was not a candidate for surgery. She would never wake up. So our only option left was to do a TAVI procedure. So she had the bi-V ICD implant. I did an angiogram, and as part of the TAVI workup, she had a CT scan. And I'll show you what we found. Basically, when I did the angiogram, coronary arteries were perfectly fine, so that was good. I looked at the gradient when I did the pullback after this left ventriculogram. She had a gradient of about 145 millimeters. So severe aortic stenosis, critical aortic stenosis. And you can see on this ventriculogram, the left ventricle is not doing much at all. It's contracting very poorly. So we do, as I said earlier, we do an angiogram to determine if they've got coronary artery disease and to see what else is going on. And if you look at this, then I followed that up with the aortogram. So before the dye comes in, you can see it's a very heavily calcified aortic valve. And the aortogram shows that the aorta itself looks okay, but she's got quite a significant aortic regurgitation as well. And if you look at it, there's just a pinhole there. And so the valve is very narrow and very obstructed. So this is what the gradients look like. You can see her blood pressure is low, and she's generating huge pressures in the left ventricle. But once we cross the valve, there's not much pressure at all in the aorta. So this is what it looked like when we started off with the TAVI procedure. And so we went ahead, did the procedure, and I'll show you a few pictures there. That's after we first deployed the valve. Because of the heavy calcification, you can see that the valve is not open fully. It's compressed. It's more like an hourglass there. So what we needed to do here was to post-dilate the valve. And once we've post-dilated it, I was happy, and you can see now that the actual valve looks much better positioned. It's open, and this is what the aortogram looks like now. There's no aortic regurgitation. So we've got a very good result, And to confirm that, this is what the hemodynamics look like. The top one, as I showed you earlier, low blood pressure, severe gradient, so that's the LV versus the aortogram, and this is immediately after. You can see there's minimal gradient across the aortic valve, so we got a very nice result. And in fact, as soon as we deployed the valve, the hemodynamics started improving, and we could in fact see that the LV function started to improve immediately after. So the patient went home a couple of days later, and I want to show you a follow-up echocardiogram, and you can see that now the LV function is markedly improved. It's contracting well, and in fact her LV function, when I saw her about a month later, her LV function was back to normal. This is what the valve looks like in a cross section. It's well opposed. It looks circular, and this is what you would expect from a well deployed valve. Once again, looking at the LV function on an echocardiogram, you can see that the heart function has improved. She's still got a little bit of pericardial effusion, but I don't think there's anything to worry about there. So that's Mrs. CMB. 1 month later, breathlessness had settled down completely. LV function was normal, resolution of her mitral regurgitation, and she was back to leading a normal life. So somebody who is almost about to die. So I think that was a great result. So I'm going to present another case, just an example of the patients that we see. Now this lady, she's 90 years of age. She's got a lot of comorbidities, as you can see: hypertension, hyperlipidemia, ex-smoker, previous stroke, left carotid endarterectomy. But the main reason she came to my attention was that she needed back surgery. She had severe back pain, and she was really so affected by this back pain that she was now confined to a wheelchair. She could not walk. So she was in dire straits. I went to see the neurosurgeon, and when the neurosurgeon found out that she had severe aortic stenosis, obviously she was no longer a candidate for having that back operation. So she came to my attention, and the only way we were going to get her across the line was to consider TAVI. And now we couldn't really figure out whether she was getting short of breath, because she couldn't do much, right? I'm sure if she could walk, she would be getting short of breath, because she did have severe aortic stenosis. So as part of the workup, as I said earlier, we do an angiogram, and in her case, she had significant LAD stenosis. So I fixed that up, I put a stent in, and during that procedure, I also assessed the aortic valve, and sure enough, she had severe aortic stenosis with a pullback gradient of 50 millimeters mercury. In her case, the valve function was normal. I'm sorry, the LV function was normal. So once we fixed up the LAD, we brought her back in and did the TAVI procedure. The procedure went very well. She had no complications, went home a couple of days later, went on to have her back surgery, and now she's mobile and independent, and with improved quality of life. So as you can see in both of these cases, having the TAVI procedure has made a big difference to their quality of life, and in fact probably extended their life. So I hope this gives you a good summary of what the TAVI procedure is. It offers an alternative to surgical management of severe aortic stenosis. We can treat patients who otherwise would not have had any intervention whatsoever. Having had the procedure, the patients tend to have a better quality of life and also survival. And initially, we started doing these procedures for those candidates or patients who were not suitable for surgery, so elderly patients. So we started with high-risk patients. Now we're doing intermediate-risk patients, and I think in time to come we'll be treating low-risk patients as well. And I believe it'll become the first choice for all comers down the track. So I'm happy to take questions from anybody regarding the TAVI procedure, or anything that you think you want to ask.
Dr. Khatri, thank you very much for that presentation. I certainly find aortic stenosis and TAVI in particular a very interesting topic. Shailesh, we have had a number of questions come through, and I can just read those out now. And if we could get you to just address some of these questions, that would be terrific. Look, the first question that we had in was, when and which patients should I refer for TAVI?
Any patient who's you suspect has got severe aortic stenosis and or a symptomatic, and you think would benefit from getting, first of all, evaluated by a cardiologist, I think you should consider sending them to a cardiologist, specifically an interventional cardiologist who does TAVI. And then we can decide whether the person actually needs the procedure in the first place or not. So somebody with a loud murmur of aortic stenosis may not have significant aortic stenosis, so we may hold off until the timing is appropriate. So that may not be always obvious when you see them in your rooms in your GP practice, but feel free to refer them, and then we can assess the patient and decide whether the patient is appropriate and whether we should actually go ahead with the procedure.
Okay, excellent. Thank you, Dr. Khatri. There are certainly a few more questions here. Let me just have a look. The next one we have is, how do complication rates compare between open heart surgery and TAVI?
So the complication rates are quite comparable. And in fact, if you look at it, if you're doing lower risk patients, the complications rates are even lower. So the things that we normally look at, any patient undergoing an open heart procedure, you'd be thinking of death, a heart attack, cardiovascular complications, or stroke. So all of these complications are possible with the TAVI procedure as well. And so they're quite comparable in many ways. But the advantage of TAVI is that it's a less invasive procedure. And the other advantage of TAVI is that we can do these procedures in patients who otherwise would not be candidates for surgery in the first place. So we're giving an opportunity for these patients to have a comparable procedure with comparable complication rates who otherwise would have missed out.
Okay. And we have another question comparing open heart surgery and TAVI as well, and that is, how long does a TAVI generally last compared to open heart surgery?
We do not have long-term data on how long these valves will last. We think they would last about the same as a tissue valve implanted surgically. So normally with a tissue valve, surgically implanted tissue valve, we say 10 to 15 years. And that's what we're expecting with the TAVI valve as well.
Okay. And so quite comparable by the sounds there. Does TAVI need anticoagulation?
No, it doesn't. It's not like putting a stent in. With TAVI, we just go with either aspirin, or if they're on oral anticoagulants such as Eliquis or Xarelto or Pradaxa, we would just continue with that.
And Dr. Khatri, we have had a few questions about the actual process with TAVI as well. The first one here is, what happens to my patient after their TAVI?
Right, so after the TAVI, the recovery is obviously much quicker than if you had a surgical aortic valve replacement. So quite often, most patients would go home 2 or 3 days later. Obviously, some would stay a bit longer if they've had complications, or they're just not physically fit enough to go home because they're old and frail, so they may end up in rehab. So it all depends on the type of patient that we're treating. But generally, you can say the patients can go home 2 or 3 days later. They should be back to normal activities within a week.
Okay, thanks. Thanks for that. And another question here, a little similar, is who looks after the patient after the TAVI? How does that work?
It's going to be your interventional cardiologist who did the procedure. Obviously, they would go back to their GPs for regular follow-up. quite often they would go and see the GP a week later because they've had a procedure in hospital, make sure the wounds are okay and there's nothing to be concerned about. If you look at patients who require follow-up from my practice protocol, normally I'd see them a month later, and hopefully after that, just on an annual basis.
Okay, thank you. Thank you, Dr. Khatri. Look, the questions are still coming in. If we haven't answered your question just yet, please bear with us. There are a few coming through and we will try to get to all of them. But if we don't get to your question this evening, please just be aware that we will send them on to Dr. Khatri after the webinar, and he will actually be contacting people by email as well. So all your questions will be answered. Now, there was an interesting one that came in here. Is there anyone who shouldn't have a TAVI?
Yes, I think if patients who, first of all, who do not have severe aortic stenosis should not have the procedure in the first place. So that's one. Or patients who do have severe aortic stenosis or who are severely demented, I feel that should not have a TAVI either. So there is a certain group of patients who would be excluded. Yes.
Okay, thanks. Another question here is, how has TAVI changed or evolved over the last few years?
So that procedure has evolved, like you would expect any new procedure to evolve, more in a technical side of things. The equipment has become better, more easier to use. It's more easier to implant the valves. Plus, of course, as we become more experienced as operators, we're becoming better at doing the procedure as well. So it has evolved quickly in the last 5 to 10 years, and it's likely to continue to evolve as we go along.
Thank you. Look, the next question we have, Dr. Khatri, is actually about the insertion site. Where is the usual insertion site and what are the options?
So I went through that in my talk. Most of the TAVI procedures are done via the femoral artery route, so that would be more than 90%. And then you've got the small number of subclavian approach, and even a smaller number of transthoracic approach. But the majority would be the femoral.
Okay, thank you. Look, Dr. Khatri, thank you very much. I'm actually just wondering, is there anything else that you would like to add? Is there any other advice or any other recommendations that you might be able to share with us?
So my main advice would be that if you have patients with shortness of breath or getting exertional chest pain or unexplained syncope, please refer them to a cardiologist, or if not, and if we can't do that, at least get an echocardiogram done just to make sure that they do not have any significant valvular heart disease, and specifically around this topic of aortic stenosis, because these patients can be treated and managed well moving forward. Yeah,
thanks. Look, that is absolutely brilliant. And if anyone has any questions after you've been thinking about this topic, or if there are any questions that we haven't quite had time to get to this evening, we certainly do invite you to contact Dr. Khatri directly, and his details have been provided on the screen for you. And certainly if you sent through any questions during the webinar that we haven't quite got to, we'll make sure that, that you're emailed with a response as well. And look, Dr. Khatri, thank you for making yourself available. Certainly if anyone has any cases or patients that you do wish to speak to Dr. Khatri about after the webinar, please feel free to contact him directly. So thank you, Dr. Khatri, for joining us for this webinar this evening and for telling us more about aortic stenosis and TAVI in particular. And thank you for joining us as well, everyone, and we certainly look forward to perhaps meeting you at our next webinar event. Thank you.
So thank you all for listening, and thank you to Mel from Medtronic for facilitating this webinar, and to Jason for all the technical support.